Okay, welcome everyone. Welcome to this new webinar organized by the European Burden of Disease Network. Today we have the honor of having Professor Stein Emil Vollset with us today. Professor Vollset is professor at the Institute for Health Metrics and Evaluation, where he is leading the GBD forecasting endeavor. And Professor Vollset today will present us the methodology and results of the global burden of disease forecasts. Before I give the floor and the word to Professor Vollset, I want to give you a general introduction to the European Burden of Disease Network for those of you who aren't yet familiar with the network. So the aim of our network, which is supported by COST, the aim is to bring together people from across Europe, but even beyond Europe, people with an interest in burden of disease assessment, allowing us to share our experience and expertise with burden of disease. If you're interested to learn more about our activities or signing up to become a member of the network, don't hesitate to go to burdeneu.net, where you will find all the relevant information. During the webinar, we will ask each of you to keep your microphones and videos switched off so that we can focus on the presentation. But after the presentation, there will be time for questions and answers. So you can use then the chat box or the Q&A box to ask your questions, or you can raise your hand and directly ask your question to Professor Vollset. So with that, and without further ado, I want to now give the floor to Professor Vollset. And yeah, I'm very happy to have you in this seminar and very much looking forward to your presentation. So thanks a lot, and the floor is yours. Thank you.
Okay, so yep. Thank you, Brecht. And yeah, you can see the presentation now.
Yeah, perfect.
Okay, so yeah, I'm very happy to be invited to this webinar and share the work we are doing at Ischemic on forecasting. And it's a relatively big and complicated system, but so I cannot go into the details of every component, but I will try to give you an overview of how we are approaching this, and also I will also discuss a few of the things we actually are improving at the moment, and also what you can expect to come from us in the next year or so. So forecasting the global burden of disease has a long history. These are the first papers with forecasting out of GBD were published in the Lancet and in Science in the 1990s, and we published now the first forecasting paper out of Ischemic in the Lancet in 2018, and that was a forecasting framework for forecasting mortality and life expectancy and measures that follows from that, like years of life lost and cause-specific mortality. And we also published and developed methods for forecasting attributable burden, which is a part of the machinery we are actually revising at the moment. And then last year, also in the Lancet, we published, using the same machinery, basically, a population forecasting paper where we forecasted population for 195 countries until the end of this century, where we actually see a peak of the world population in the mid 2060s and then a decline to just below 9 billion in 2100, actually 2 million below the UN estimates. But that's not the focus of today's talk. Today I will discuss first different types of scenarios that we have established in the forecasting framework. I like to start saying that we do not pretend that we can see the future, but we are trying to give you a reference scenario, which is what we can expect to happen if trends in independent drivers of health continue to follow recent trends. And independent drivers is a key component of our framework that I will come back to. That is, for example, when we forecast lung cancer mortality, smoking is an obvious driver of that. So, and smoking is an independent driver of mortality. So so we first forecast smoking exposure for every country and age and sex into the future, and that is input to the mortality model. And then we also have to assume for the reference scenario not only that the drivers follow recent trends into the future, but also that causal relationships between the drivers and health stay the same in the future. So the reference scenario is not a prediction of what will happen, it's simply what would happen based on forecasting past trends in drivers and past relationships between drivers and outcomes. And we have a large number of independent drivers of health that I will come back to. And in the first forecasting paper, the mortality paper, we produced what we call better and worse scenarios. And these scenarios are sort of, I think of them as more of bounds on what are possible futures, and the basis for these are rates of change of each independent driver. And we have two settings. One is the 85th percentile of observed rates of change across locations and past years, which will give a better future in terms of health, and then the 15 percentiles of setting of the rates of change across countries and years in the past. And these scenarios, we set every independent driver either at the 85th or the 15% scenarios. And in addition to this, our framework also allows for tailored scenarios of alternative future trajectories for any combination of the independent drivers in the model, and I will come back to that because it's a key area we have been working in lately. I'll just mention a few of these tailored or custom scenarios, which are examples from some analysis we have carried out. When we did the population paper, we constructed population scenarios based on the two drivers in our fertility model, which is female education and met need for modern contraceptives, and we kept all the other drivers of health as reference. Another analysis that I will come back to is actually we model all the dietary risk factors in the GBD, which is 14 or 15. And if we set, and we can create a hypothetical future, if we say that between now and 2030, we assume that all excess risk from diet will go away, and we keep all other drivers at reference, and then we can see how that will affect mortality and burden. And we also have done some work on climate and forecasting temperature and carbon emissions, and then we constructed scenarios for all countries according to the Paris Climate Agreement goals in 2030. But I want to come back to the independent drivers. In a way, they are the heart, or the sort of the heart or basis for our forecasting method, and also what distinguishes us from others. For example, demographers typically do population forecasting without using drivers, just based on past time trends in fertility and total fertility rate and all-cause mortality, whereas we try to model the causal relationships, basing that on the comparative risk assessment in the GBD, and link risk factors to the future mortality and trajectories of other measures like incidence and prevalence. We have two basic types of independent drivers. Our main driver of health in the future is what we call, it's the social demographic index, the SDI, which is a GBD invention. That is it is a composite of GDP per capita, educational attainment by country, mean years of education, and the total fertility rate under 25, and they are combined into an index from 0 to 1 across all countries and years. And we also forecast this index into the future to 2100, and this is done not only for the country locations but also at the subnational level. And then the second large group of drivers of health is all the risk factors included in the GBD, which is, if we count clusters of risk factors, it's close to 80. Individual risk factors, I think it's around 68 or something. And we also use interventions. For example, we forecast 5 vaccines, and we also have a separate model for HIV/AIDS incidence and mortality, actually done outside of our main framework and done by another team at Ischemic, and they use the specific drivers for HIV/AIDS incidence and mortality, like ART coverage and others. And this slide shows basically all the drivers of health that we actually have to forecast before we can start the forecasting of mortality. So if we, in the upper left corner, we have the social demographic index, which is education, income per capita, total fertility rates under 25 years. We have the 5 vaccines that we are included in our framework, and then comes all the risk factors included in the GBD, water, sanitation, hand washing, and then air pollution, on other environmental risk, and all the occupational risks in the second column, and then child and maternal malnutrition. In the middle column, tobacco, alcohol, drug use, and the diet risk factors in green in the third and fourth column, and then intimate partner violence, childhood sexual abuse, bullying, unsafe sex, low physical activity, and the metabolic risk factors, fasting plasma glucose, LDL cholesterol, blood pressure, body mass index, low bone mineral density, and impaired kidney function. And I will come back to how we incorporate this into the mortality model, but we also use some of these risk factors as direct covariates in the model for select causes. And then at the end, in the lower right-hand corner, we have the drivers of HIV/AIDS in that model. And first of all, I'd just like to say a few words of how we forecast the GBD risk factors. What we forecast is what we call in the GBD, we call it SEVs. It's the summary exposure value, and that's another GBD invention that and it's a risk-weighted prevalence measure that puts any risk factor, be it binary or categorical or continuous, on a common scale from 0 to 1. And until now, we have used a simple rate of change model without covariates to forecast the risk factor SEVs. We are actually changing that at this point in time, and some of you may have heard of Mr. BERT, which is IHME's new Bayesian meta-regression tool that is now used in many applications we do. And the advantage of the Mr. BERT models for forecasting the risk factor SEVs is that we can include social demographic index as a driver of the risk exposure. And to stabilize our modeling approach, we actually do this for an ensemble now, with one set of models is the old rate of change models, and then we have two different types of Mr. BERT models, and we also weigh the past differently in the input. And this is a promising approach that seems to give more stable results for our future trajectories of risk factors. Then another key thing that we have started to look into is risk factor mediation. And this is just a slide to show the concept of mediation. For example, body mass index exerts its effect on ischemic heart disease as a direct effect, showed with the black arrow, but also by raising blood pressure, raising LDL cholesterol, and raising FPG. So these three are mediators for BMI's effect on ischemic heart disease. And we see that so mediation is characterized by this pathway, BMI through mediator to outcome, and every of these pathways has a mediation factor, which is the proportion of excess risk that is mediated through each mediator risk factor. And we see that a third of BMI's excess risk is mediated through systolic blood pressure, and 10% through LDL cholesterol. And actually, for those of you who have studied the risk factor machinery in the GBD in detail, you will have noticed that we have something. We have a construct we call the mediation matrix, and for GBD 2019, that mediation matrix consisted of 135 risk mediator cause entries, of which BMI through SPP, LDL, and FPG to ischemic heart disease constituted 3 of these 135, each with a mediation factor. And the main motivation for the use of the mediation matrix in the GBD has been to avoid double counting when calculating disease burden attributable to clusters of risk factors. For example, all risk factors combined or all diet risks combined. But when we started to delve into the issue of forecasting risk factors, the novel use of the mediation matrix is actually now to construct believable future risk factor trajectories. For example, if we set a specific trajectory for BMI into the future, be it that it stays constant in the future or go down or increase, that setting will also have to affect the future trajectories of, for example, of systolic blood pressure, LDL cholesterol, and FPG. And that connection was absent in our framework until now. So to support development of policy relevant scenarios, we have now been looking very closely at this mediation matrix, and we are going to change it quite substantially and expand it. And we have also developed a new concept that we call the intrinsic summary exposure value of risk factors that are mediator. And that is the level of, for example, a mediator like systolic blood pressure that is not explained by trends in the distal risk factors that flow through mediator. For example, the main distal risk factor that flows through systolic blood pressure is salt intake and BMI. And I just wanted to show, this is an analysis we did a couple of years ago for the Rockefeller Foundation, and it's just what I mentioned earlier in the talk, that we set the diet, we let the risk exposure from the diet risks go to zero between 2020 and 2030. And then the forecasting framework suggested that in the old framework that attributable deaths to poor diet would be 11 million. But when we switched the approach and just set the SEVs to zero, we noticed that we avoided only 4 million deaths in 2050. And when we started to look into this difference between the 11 million deaths with the old approach and attributable future burden compared to what we saw when we manipulated the SEVs of 4 million deaths, we found that it's the lack of linking the trend in the mediators like blood pressure, fasting plasma glucose, LDL cholesterol, to their distal risk factor that flow through them. So to solve this problem, between the 11 million attributable deaths and the 4 million avoided deaths, we are now using this new intrinsic summary exposure value. We have revisited every pathway in the mediation matrix. We have we have taken some out, and we have also, due to consistency issues, when we looked carefully at this, we are also expanding the matrix quite a bit. And I think at the moment we have a mediation matrix that is about twice the size, with around 270 entries compared to the one we used for GBD 2019. And we are also constructing a score system for the risk factors, and we use that scoring system to help guide inclusion of new risk outcome pathways to the GBD and to the future health scenarios. And this is just a simple graphic of what I've been talking about the intrinsic self. And and this is a visual of the contribution of the intrinsic self for blood pressure and the effect of the distals, which are many, but the two major are BMI and salt intake. And on the left-hand side, you can see from for USA and India, you can see past and future trajectory of the total blood pressure. In the US, it's going down to around 2010, and then it seems to be increasing. And in India, the top blood pressure SEV is staying relatively constant from 2010 and to 2050. And on the right-hand side, you see when we now in our new system manipulate the diet risk factor, of which one of those is salt, and set salt and the other diet risk factors to 0 between 2020 and 2030, we see that the contribution from that distal to the blood pressure summary exposure value disappears, and we see that the change in that in salt intake and other diet risk factors has a clear effect on the future trajectory on the systolic blood pressure SEV. So it goes down and then continues upward with the same trend in the US, and it goes down and stays flat as before after that in India. This is the key novelty we are building into this the framework that eventually will produce avoidable burden for the GBD. This is just another example of intervention, in this case vaccines, that we have to forecast for every country in the world. These are the global estimates for the 5 vaccines that are included in our framework. The diphtheria, tetanus, pertussis vaccine, the Haemophilus influenza type B vaccine, measles vaccine, pneumococcal, and rotavirus. So now we are getting to the, now that we have forecasting all the drivers and interventions, and the few interventions we also include, like the vaccines, we are ready to forecast cause-specific mortality. And of course, we now have forecasted the social demographic index. So the first thing, we do not forecast the observed. We have, to start, we are forecasting a little more than 200 cause-specific mortality model, and we forecast them separately for males and females. So we have to do the mortality part of the forecasting, we have to run around 440 models, 220 causes for males and females separately. But we do not forecast directly the observed mortality or cause-specific mortality. we actually remove the effects of risk factors and interventions. So what we are forecasting is what we call either risk-deleted mortality, and we also call it underlying cause-specific mortality. And those who are interested in the details of this can this is described in the appendices of both of the two Lancet papers we have published. So and the risk factors are linked to the model as a scalar, as an offset, and it can be it's actually it's an offset on the log scale, because we model log mortality, and on the natural scale it's a multiplier of mortality rate that we construct from the paths that are connected from each risk to the set of causes that risk has a causal effect according to the GBD comparative risk assessment system. And once we have this underlying mortality, and I will show the model in more detail on we are using a mixed effect linear model with age, location, and age time random effects, and the main covariate is the social demographic index and time as explanatory variables. And after that we do run a series of ARIMA models on every level of the cause hierarchy, from the cause specific to level 2, level 1, and all cause, on the residuals of the second step, to capture what's not explained by risk factors or the SDI time model. So this is from the appendix of the population paper, and those who are interested can read more on the details of this model. I think and I think that the heart of this is actually this log scalar, which actually links the risks to the model by this scalar, which is 1 over 1 minus the path for the cluster of risks that are linked to each cause according to the GBD CRA. And as I said, we do this separately by cause and sex, for males and females. This is an overview of sort of the forecasting framework, and it's a complex system. There is a lot of different methods built in, and all of this is built in-house, and it's also a huge computational effort needed. It takes us about a week to sort of run through the machinery on our relatively big cluster, and forecasting. We now have to sort of to handle all the data and all the forecasts. We now have around 2 petabytes of disk space that we will be expanding in the next year, I hope. I won't go into the details of all of this, but just point that we need to forecast fertility, because we need future population to sort of get the rates right, and the counts. And the main drivers of the fertility model is met need for contraception and education, female education. Female education is also needed with forecast to construct the future socio-demographic index from education, from fertility, from GDP, and then all the risk factors have to be forecasted and covariates, and then those are input to the cause-specific mortality model, from which we bound by the past all-cause mortality. And I will come back to how we are now also estimating incidence and prevalence based on another set of models with SDI as main covariates that will give us YLDs and DALYs, and of course we also have the population forecasting framework that not only need age-specific fertility rates as input, but also migration and all-cause mortality. And this is just I won't spend too much time on this, and this is also something that we have not published yet, but our next paper, which I hope will be relatively soon, will be what we call the DALY paper, that we extend the mortality forecasting paper that we published in 2018. We will expand it to forecast not only mortality, but also incidence, prevalence, YLDs and DALYs, and life expectancy as before, and also healthy life expectancy. And to estimate incidence and prevalence, we divide the causes into acute and chronic, and we model future incidence directly via the mortality incidence ratio in a mixed effects model again, with SDI as the main covariate, and the chronic conditions with the mortality to prevalence ratio in a similar mixed effects model. And we also have the non-fatal only causes, which is around 60. We model them in the model shown by equation 2, which is the prevalence only model, where the input is past prevalence and SDI again the main covariate. So to sum up what I call the forecasting granularity, the mission of our forecasting team is to forecast each round of the GBD. And so now we are forecasting the 369 GBD 2019 causes and cause aggregates, with only a few exceptions. We do this for 23 age groups, males and females, and for 204 country locations. And we also make subnational estimates at the moment for China, India, United States, and Brazil. And we produce cause-specific results until 2050 for all main GBD measures. That's YLLs, YLDs, DALYs, incidence, prevalence, life expectancy, and HAIL, as I mentioned. And we also have the capacity to do 2100 populations. And after the plan, after the DALY paper, which is our next big publication, is to publish avoidable burden using our novel approach to forecasting risk factors. And in the remaining few minutes, I will just show a few, and I might not show all of this, but a few examples, graphical examples of how the results look. So this is global age standardized death, YLL, YLD, and DALY rates from 1990 to 2050. And at the GBD level 2 cause level shown on the right, where we have, I think it's 22 cause groups. HIV and sexually transmitted infections we see at the bottom in yellow, and then we have respiratory infections in green and TB. Then we have enteric infections where the main contributor is diarrhea. Then the neglected tropical diseases, other infectious diseases, maternal neonatal disorder and nutritional deficiencies, all the way up to the black band, which is cancer. And the red band is cardiovascular diseases, and followed by chronic respiratory and digestive in dark green, neurological disorders in light green, and mental disorders in blue, which only are visible in the YLD estimates, where we see that the major, as we all know, where we see that the major contributor to the non-fatal burden is mental disorders in blue, and then musculoskeletal disorders in brown. And whereas we see that the death rate is going down, the age standardized death round globally, and also YLL, the non-fatal burden stayed relatively constant in the past, and is forecasted to stay relatively constant into the future. And then on the right-hand side, we have the main burden measure, which is the sum of the YLL and YLDs, and we can see visually here how we can see the various components from the YLL and YLD in the DALI graphic. So this is global. On the next slide, we see it's the same graph for sub-Saharan Africa, where you can see the huge impact of the HIV epidemic that peaked in the early 2000s on the deaths and on the years lived with, or the years of life lost. And we can also see that the YLD component of DALIs is much smaller in sub-Saharan Africa compared to the YLL component, but it is an increasing proportion of the DALI over time as YLL rates go down. And on this slide, we see exactly the same slide for high income countries, where we see that the contribution from the communicable maternal, neonatal, and nutritional causes is relatively minor, shown under the black band, which is neoplasms. Below that, we have that the communicable group, and we see the dominance of cancer and cardiovascular disease in red on the age standardized death rates in high income countries. And we also see the dramatic decline in the contribution of cardiovascular disease to the mortality burden, so that a much larger proportion of deaths will be cancer and other non-communicable diseases than cardiovascular in the future. We also see that already around in the early 2000s, the YLDs in high income countries was half of the DALIs, and we see that in 2050 the YLD component of the DALI is well above 50%. And we see on the right hand side the contribution of musculoskeletal and mental disorders and neurological, which is both dementia, but also headache and other neurological diseases are large contributors to the DALI compared to cardiovascular and also to cancer. And on the top of these graphs, we can see the injuries, the unintentional injuries and self-harm and homicides. And this is, I think I will, this is what I call the all-in-one DALI plot. Here we can see in 2019 at the bottom, for every country in the world, we model ordered from high-income countries on the left-hand side, and then Central Eastern Europe and Central Asia, North Africa and Middle East and South Asia, that includes India, and then Southeast Asia and Oceania, that in Southeast East Asia, that includes China in the super region, Latin America and Caribbean, and on the right-hand side, Sub-Saharan Africa. Again, we see the actually here we have separated this is the YLD component of the DALI is towards the center of the plot, below the white line for 2050 and above the white line here for 2019. And we can see it's relatively constant over across countries and over time, with much less variation than we see in the YLL component, where there is a dramatic difference between, say, high-income countries and Sub-Saharan Africa, and also some parts of South Asia and Southeast Asia and Oceania in particular. And we can also see here visually that the YLL component will decrease between now and 2050. In this slide, it's exactly the same slide, but it shows we have taken away the demarcation between YLDs and DALIs, and we can see that the DALI rates are decreasing. And in the next slide, I'm actually showing the difference, the decrease in mortality by cause between 2019 and 2050, shown at the bottom, and the mortality in 2050 in the top panel. So we can see that the decrease in high-income countries is from cardiovascular and cancer, and especially for Central and Eastern Europe and Central Asia, we can see that the decrease we forecast in the next 30 years is dominated by decrease in cardiovascular mortality, and the same holds for North Africa and Middle East, and also many countries in Southeast East Asia and Oceania. Whereas when we go to Sub-Saharan Africa, we see that the decrease we forecast between now and 2050 is mostly among the communicable maternal, neonatal, and nutritional causes. And I think I will skip a few of the coming slides and go to the final slides, where I'm just summing up again that our mission is to produce full forecast at full GBD granularity and do all measures coming soon, death, YLL, YLDs, DALIs, incidence, prevalence, life expectancy, HAIL, for 360 causes, 375 locations, 23 age groups by sex until 2050. And a key feature of our forecast is that they are covariate driven by all the risk factors and interventions. And a unique feature is the potential that we can produce tailored scenarios. And we will, with the current improvements and also using the mediation matrix to guide future risk factor trajectories, we will greatly improve our capability to produce relevant policy scenarios. I think I will stop there, so we have a few minutes for questions or comments.
Yeah, perfect. Thanks a lot, Stein Emil. So this was indeed a very interesting and important insight in the GBD forecasting framework. So thank you very much for that. So I guess we are all very familiar with the GBD study as such, but this is one of the many hidden gems that are there at IHME. So it's good that you were able to present this. So thanks a lot. I would like to give the floor to Henk Hildering from the Dutch National Institute for Public Health and the Environment, who will guide the discussion section or session, so the Q&A session. So Henk, feel free
Yes, good afternoon, and thank you a lot, Stein and Emil, for this very nice presentation. Good overview of all the activities on forecasting that are going on at GBD. I was looking at the chat, actually. If I can see some questions, please, you can ask your question in the chat, or maybe unmute yourself or raise your hand. But let me start with asking you the first question, actually. You were indicating that the socio-demographic index is playing an important role. And I think, especially for developing countries, that might be a very dominant factor. But is it also the case for developed countries, actually? And aren't there many more factors that might play a role there as well?
That's a very good question. I think the SDI is, when you do global analysis, it is a very strong driver and determinant of health across all countries and into the future. But as you know, in high income countries, changes are relatively minor and there is a ceiling. So, and of course, there are effects that are not captured by, or changes happening in high income countries that are not captured by the very small changes we see in either direction happening in high income countries. So, and you know, so yeah, that I think my only my answer here is to acknowledge this as what you are pointing to is indeed correct, and we might need to incorporate other drivers than SDI. And actually, in fact, for some of the cause-specific models, we do add, for example, risk exposures in addition to SDI. So, for example, when we forecast diabetes mortality, SDI is not the only covariate in the model. It's also fasting plasma glucose levels. And also remember that sort of the trajectories of mortality in the future are also captured by the risk factor scalar. So trends in risk factors are influencing our forecast in addition to the SDI. So we are not relying on SDI alone.
Okay, thank you very much. Then I have a question from Brecht, actually. Can you say something about how the COVID-19 pandemic might affect the forecast that you are producing?
That's a very timely question. I agree. And you know, what happened with COVID is that forecasting has become much more challenging than it used to be. Many of the trends we have seen are relatively stable in the past and also into the future, and now all of a sudden we have a pandemic that is much more unpredictable. So what we will be doing before we will publish our DALI paper is that we, as you may know and have followed, the Ischemic has built a substantial global COVID model, and we are releasing new estimates every week, and we are running this COVID model for 2021 and 2022, and we will incorporate that in our new forecasts. But how COVID long term is it going to be an infectious disease we will have for 2 or 3 more years, or will it be a permanent or potentially seasonal disease like influenza in the future? We do not really know. It depends.
Yes, thank you. Yeah, and then you're entering much more the let's say the foresight arena instead of forecast arena, when you acknowledge those structural uncertainties that play a role, like a virus in the future. I have another question from Francisco about if the update for the mediators of the mediation matrix is becoming available. Could you say something about that? If the information that you're using to do the forecasting, is it completely available to the public?
Once this is done and published, the mediation matrix will also be made available, as it has been in the past, I think, in the appendices for the rounds, since I think the mediation matrix was introduced in GBD 2013. So it's been around for a while, but it's been used mostly, as I said, for calculating burden for clusters of risk factors. Now we are using it for
maybe giving the time. I have a question from Zubair, and that's regarding the updates that the GBD is making. And you were also mentioning yourself that the new calculation of the new methodology about diet, then the number of avoided deaths reduced from 11 to 4 million. And of course, that is something that you always have to communicate to policymakers. That's also the question from Zubair. With every round of GBD, we might have different outcomes. How to deal with the communication to policymakers of those revised and obviously better results? Can you say something about that?
This, of course, I do not know if this 4 million is the correct estimate. We will not know that until we now have been running through on the new mediation matrix. So that's a preliminary estimate done a couple of years back. So don't take that too seriously. So that could become, I will not make a guess on that. But that's the whole purpose of going through the mediation matrix and going through the burden forecasting to understand better the estimates and how they are and how they come about, so that we can reconcile or explain why we got 11 and what the new number will be. I don't know yet.
But you do agree that it might have give some problems in communication, for example, to policymakers, that you have a revised result that is deviating from the previous result quite substantially.
Absolutely. But we need to see the new result first, and then I absolutely agree that this is it is important that we are able to communicate why things change and what are the reasons they change. If not, we are in trouble.
Okay, thank you very much, Stein Emil. I think it's 5 already here. I think it's a bit earlier in your place. And I will give back the floor to Brecht to close the session.
Yeah, thanks a lot. I would maybe just want to ask or add if anyone would have further questions, please feel free to reach out to us or directly to Stein Emil, and I'm sure there's a lot more we can discuss about. Stein, I want to thank you once again for this very nice presentation, and thanks to everyone for being here. The presentation will also become available through our website if you want to have another look. With that, I want to wish you all a very nice afternoon or day. I hope you will enjoy watching football later today, and then we will see each other soon the coming weeks and months. So thank you all very much and have a very nice day. Thank you.
Okay, and thank you,
Bye
Brian,
bye.
for having me.
Bye to everybody.